Thank you for tuning in to TalkWad.com, the world's fastest growing internet radio network. Please check out all the other great shows on www.talkwad.com.
What if your customers are trying to find your business online, but instead of finding you, they find your competitors? Now, more than ever, it's time to make sure you have the right SEO to make your business stand out online. Welcome to Go Mind Your Business with Terry Bork, presented by Extreme Marketing Concepts, putting your business in front of the hungry herd of buyers who are looking for you right now. Extreme Marketing Concepts, helping you drive more traffic, dominate the market, and crush your competition. And now, here's Terry.
Hello, everybody, and welcome to another edition of Go Mind Your Business here on the All Your Business Radio Network. Today, I'm really excited. I've got two amazing guests that I'm going to share with you. The first is John Boudreau, and the other is Jerry Quintana. And today, we're going to be talking about Obamacare. Gentlemen, welcome to our program today.
Thank you, Terry.
Thank you for having us.
Oh, it's my pleasure to have you. Let me share with you a little bit about Jerry and John before we get into Obamacare today. John, to my right, has an excess of 30 years experience in the healthcare arena. John has been active in several arenas from medical consulting, senior executive search, CEO, CFO, vice president, etc., physician placement and contract negotiation, to the acquisition and amalgamation of medical entities. The federal government sought an additional company to certify foreign-trained medical professionals, and John and his associates initiated the planning and fulfillment of that task. Jerry Quintana has been in the medical services field for several years. He specializes in technical support, customer service, and technical sales for over 24 years with organizations like the U.S. Army, Hewlett-Packard Dell, USF, Hillsborough County, Florida, Best Buy for Business, Interstate Brand Corporations, whose companies include Hostess, Merita, and Wonder Bread. He builds, and manages relationships while fulfilling customer service satisfaction goals and sales quotas. Together, John and Jerry endeavor to bring the medical community full disclosure and compliance with the Affordable Health Care Act, or Obamacare. Their ultimate goal is to bring preparedness and awareness to our medical professionals of the requirements necessary to complete the Obamacare audit. And this will enable the medical community to move forward effectively during the massive transition in the delivery and receipt of our medical system. So again, gentlemen, welcome to our program today.
Thank you.
You're very welcome. So I guess, John, let's start with you if we can. Tell us a little bit about what the Obamacare audit is.
Well, the Obamacare audit is really something that has been designed to help facilitate the transition that's going to occur for doctors and medical practices, as well as the healthcare on the whole, from the self-payer system that we have right now, dealing exclusively with insurance companies, et cetera, to the managed care that's going to be provided under the Affordable Health Care Act, which is going to be a dynamic change that's going to occur, especially for the doctors. It is going to affect everyone, of course, because we're going to try to bring here in the United States everyone into a one-payer system. Although it isn't designed that way, it's the way it's going to be developed, since everybody has to be involved. The insurance companies are still involved at this point, but we'll see how that progresses as Obamacare rolls out.
Mm-hmm. Okay, great. Now, I know that you guys have a website, www.obamacareaudit.com, that folks can learn more about what you do and how you can help in the medical field, correct?
That's right. And we're also going to be launching a separate website, which will be under one of the primary companies that is within our organization, and that is Medical Management Systems.
Mm-hmm.
So that's going to be another website that will be up and running probably within the next 10 days.
Terrific. Okay. So, Jerry, what is the objective of Medical Management Systems?
Our objective is actually to make the doctors' lives easier in the fact that we can bring them to a point where all they're doing is practicing medicine and spending their money.
Okay. Okay, got that. So, can you elaborate that a little bit on that a little bit more?
Well, what we do is we will take their billing responsibilities,
Okay.
and we will do these responsibilities for them. In encompassing that is taking their collections for their claims from somewhere between about 70 to 80%, which is what they can collect now, and taking it all the way up to nearly 98, 99%.
Oh, wow. Okay, great.
So it's really it's really a tremendous increase in their bottom line. But the bottom line really is to help them be able to afford their practices and help them be able to realize the amount of money that that they should be getting paid for the incredible work that they do.
Okay, great. I get that. Okay. So John, what is the effect of Obamacare on physicians?
Well, it's kind of a multi pronged sphere that's going to be thrust at the doctors quite dramatically. And most of them are starting to come to the realization of what that's going to be. One of the things that's going to happen is the delivery of the healthcare system is going to change dramatically. First off, how do you see more patients with the time allotted? Because at this point in time, as we all know, getting in to see our doctors is quite a challenge.
Mhm.
And that's one of the things that's going to happen, that doctors are going to have to find some way to medically manage their practices so that they're enabled to see more patients more effectively with the time that's allotted. One of the things that's going to happen that's really going to dramatically affect the doctors is the change in their income status. They're going to see more patients, but they're going to make less money.
Mhm.
Because of the thrust of Obamacare that's coming down through, and that's one of the things that MMS is going to be doing, is we're going to help doctors realize that they can facilitate income increase or income stabilization during this. Really, it's a crisis situation that's going to be afforded to them. With the rollout of Obamacare, it's going to decrease their pay almost to a one-payer system where all doctors will receive the same income. Well, that's a really difficult situation, because what do you do when a cardiologist is going to make the same money as an internal medicine?
Mhm.
Or you're going to get a surgeon who spends multiple years learning that specific craft and honing it to being paid minusculely compared to what he was receiving now. And so these are the things that need to be understood, and the changes that need to be put in place in order for the doctors to be able to continue to have the lifestyle they have and find the time to be able to do the things they need to do to succeed financially, as well as, I guess, quality of patient care, because that's a doctor's number one prime objective in this world, is to make sure that their patients receive the best care. And how can you do that if you're going to see 44 million more patients
Mhm.
with the same number of doctors? It's a challenge that's going to be faced by everybody.
I get that. Yeah. It's very scary actually too,
Well, yeah, that's one of the things. But just think, we at the office, in my crew, we've gone through the Obamacare or the Affordable Health Care Act, whichever way we want to announce it. And President Obama is very happy labeling it Obamacare. We've gone through that several times, explicitly trying to find out exactly how we can facilitate this change or help facilitate this change while maintaining the doctor's status in the communities. And it's difficult. It's difficult for multiple reasons. One, of course, is because of the extra patient population. Another one is the fact that we are training many, many, many doctors who could help us and assist us in growing or facilitating the care for our patient population, but they don't stay in the United States. They're here on H-1 or J-1 visas, etc. And when their education is finished, if they can't find an underserved area, they go home.
Mhm.
So here we are. We're training an extra 30% of our medical professionals who don't stay here. They want to stay here, but because of the immigration policies we now have in place, they can't do that. So I know that these things are all going to change. I know that the government is looking at all of the things that need to be done in order to facilitate this transition a whole lot easier. But what do we do in the meantime? One of the things that's going to happen, I don't know if you're familiar with it, but the coding practice that's going to happen for doctors is changing dramatically from what they have right now is called an IC9 system. That's the codes the doctors use in order to get paid and remunerated. Those are changing to a new system called IC10s, ICD-10s. Now, those codes are more explicit and more specific. So it's going to limit the amount of codes that are done, but the codes are going to be more specific to the processes that the doctors are utilizing. So what do you do when all that happens? The insurance companies aren't in place. They don't have everything in order to get that facilitated. Medicare, Medicaid don't have that in place yet in order to facilitate it. They're going to roll it out slowly. But one of the things that their doctors' practices are being told right now is you best have yourself 6 months, 3 to 6 months of available capital to run your practice, because that's how long they're looking at foreseeing there being a roadblock to getting remuneration from the work you do. So the challenges are huge. The Obamacare audit that we do encompasses everything that's going to happen in a practice, all the way from the IT side, the medical management of the practice itself, of the billing cycles, the accounts receivable and the format of all of that, as well as being able to facilitate the active utilization of the EHR and EMR systems, which are not an option for doctors. It's mandatory. If they don't have that in place by the end of 2014, they get fined every month for not having it in place. And that's something we can talk about more in depth as to why that's being put in place as we move forward here.
Okay. So let me make sure I'm understanding, what you're sharing with us here now. So basically, you guys, the ObamacareAudit.com and your managed medical management system team
Right.
can come in and basically be like an outsourcer where the doctors can go and outsource, making sure all their billing is up to date and they're compliant and their IT is handled the proper way. They can give all that to you, or they have to find a way to internalize it themselves.
That's one of the things, yes. We can actually internalize it for them, which is less effective and more costly for the doctor to do. Basically, this sounds like a sleight of hand, but we actually pay doctors to work for them.
Okay. You
So
pay the doctors to work for
yeah,
them.
because
Okay.
what happens is we come in, and if a doctor is actually receiving 72 to 82% of his income from his revenue generation at this point, what happens is we take away all of the cost aspect that he's utilizing right now to earn that.
Mhm.
So he may have a billing department of 1, 2, 4, even 9 or 10 people. What happens is by utilizing our service, he no longer has those people to pay.
Okay.
So that money, we'll say it's 9 people, just to be a nice, easy number, and we'll say he's paying each one of those people $30,000 a year. That's $270,000 that we put on his bottom line.
Mhm.
And we charge a very small percentage for what we do, but we increase his income ratio from, we'll say, give him the high point. He's receiving 80%. And we increase it up to 99%. And our percentage brings it down, just for sake of conversation here, down to a 95%. So now he's receiving 95% of his actual billing that's creditable, that he can receive funds for, and he has no internal problems. One of the biggest problems in an office staff is not the fact that they don't want to work for the doctor. It's the fact that they're stressed out trying to do the work that's required. And the billing department, accounts receivable and accounts payable, is a humongous stress on the organization. We take that stress out of the field. Now his staff does what? His staff does exactly what he wants them to do. That is, they're looking just like he is after the patients. So it's quality of patient care, more time for the doctor to see the patients, more time for his staff to deal with the patients. There's nobody calling in to change their appointments. There's nobody calling in to adjust their time schedules. That's all handled by my department. So the office staff does nothing but look after patients. So quality of care goes up, quality of association goes up, more quality time means happier people.
Okay, I got that. I keep hearing, Jerry, this term EMR and EHR. What is that? What does that mean?
And actually, the EMR and EHR are interchangeable. It's an electronic medical record and an electronic health record. And both of those are, like I said, interchangeable terms. Essentially, what it is taking the paper record that the doctor currently keeps and putting it into an electronic record that can be shared and can be viewed by the patient online on the internet, as well as other doctors, laboratory entities, and whoever else needs to have a look at this record or needs to be able to use the record in order to fulfill prescriptions, to do a doctor referral. And the other thing that it does is it makes it much more portable. So now you can have this electronic medical record in the cloud or out on a system that is accessible through the internet. And so it really gives it that same timelessness as anything else you'll put on the internet. It's there forever.
Okay, I got that. Excellent.
There's,
What? Go ahead.
can I just bump in just a second?
Yeah, go ahead.
Yeah, just to let you know what this means. Why are they doing this?
Uh-huh.
There's the question.
Well, I was just going to come right over here and ask you that, John, but you beat me to the punchline.
Well, it's really strange when you think about it, because one of the things that we have that all the practices have to have is HIPAA compliance.
Right.
Correct.
That's where your information is protected.
Correct.
But under the EHR EMR standards, what it's designed for specifically is so that if you're traveling throughout the country or anything like that, any doctor, any medical practice, any hospital can attain your records, because as Jerry has said, it's in the cloud, so anybody can access it. It would basically be accessible through your Social Security number is what it's going to be set up under, from my understanding. However, let's put into perspective what the end goal is, not the short-range goal, because the short-range goal is having it accessible to the healthcare professionals. But see, Obamacare is not necessarily designed for the healthcare professionals. Obamacare is designed for the deliverance and the paying of the healthcare costs. So one of the things, now this is directly from the Obamacare or Healthcare Act. It says on page 195, officers and employees of the new healthcare administration will have access to all Americans' personal financial records and accounts. So if you can pay, you're going to pay. It mandates that all doctors receive the same pay regardless of the specialty. This will vastly reduce the number of specialties or specialists available in the United States, a common problem where medicine is socialized, like in Canada. Now, that sounds not too awful bad. Sounds pretty bad to me. It dictates the doctor's payment and therefore income, which will reduce what doctors earn and lead to greater shortages of doctors and more rationing of care. But our health care is not going to be rationed, right?
Mm-hmm.
Yeah. Okay, I just wanted to clarify that one. Basically, what it does is very simply, there are several sections within it that allow for, if you have the funds in your account to pay for the procedure, whether you authorize it or not, the healthcare organization will be able to deduct that money from your account. These are the types of things that are coming forward in the healthcare plan. Retaining and maintaining your present healthcare, yes, that would be a wonderful thing, but it states here also that if your employer decides not to participate in paying your insurance, that the health care that you have, if they're not included in the health care exchange, you can't retain your health care.
Mm.
You have to go to another carrier. So there's all kinds of funky little things that are hidden in there that really, if you go through the Health Care Act, I mean, well, granted, it's a huge volume. There's over 2,000 pages in it, 2,080 right now. And but you got to remember one very important thing. it's already a law.
Mhm.
Obama signed it in, so we got it.
Right. Okay. But our HIPAA, so they disguised it. Really is what I'm hearing you say. What we're really getting, or not really.
Yeah, what we're getting is not really what we've been told.
No, it
Yeah.
sounds very different. And what I guess the scary part, I think, is the lack of specialists that are going to be available to us in the future.
Well, yeah, let's be honest. To specialize, and then the doctors can tell you, a surgeon, not only does he do his residency program, then he does a surgical residency on top of that, maybe another 3 or 4 years. And if he happens to be a orthopedic surgeon, well, then he's got to go and work as almost like a resident again with an orthopedic group before he gets the opportunity to be that surgeon he wants to be.
Mhm.
So if you're looking at graduating typically as a doctor at 29 to 31 years old, and you put the specialty on top of it, you're not graduating until you're 34 or 35, and each one of those years is costing you $40,000 to $80,000. So you come out with $500,000 in debt, and all of a sudden you're going to make the same money as an internal medicine doc.
Right.
A little bit scary there.
Very, very frightening there. Yikes. Okay. So Jerry, we're talking about this cloud storage. What is the end result of having all our data stored in the cloud?
Well, the end result is you're going to have tremendous redundancy. So we're not going to lose this information. It's going to be very protected. It's not like you have a server in, say, a practice that doesn't have a backup and crashes. In an instance like that, it could cost a doctor, $30, $50, $100,000 if they can recover it at all.
Mhm.
Otherwise, this information is gone,
Okay.
and that is a huge HIPAA violation.
Yeah.
So what this is doing is it's really making this data a lot safer, making it redundant, and making it available to all of the authorized personnel that will need this information.
Okay.
And we're talking about, millions of terabytes of information.
Okay, I got that. Who pays for what as far as the storage is concerned?
That's a good question. Usually, when you're using something in the cloud, let me give you a for example. AdvancedMD
Mhm.
is a company that does business in the cloud. It's an electronic. Well, it's a practice management and an EMR. So what they do is they take all that information. You can access this the EMR or the PM from any browser that is set up correctly. Once it's set up and it's HIPAA compliant and it's safe, you can go into this system and you can input information. What happens is that information is put up into their cloud, and AdvancedMD actually has a facility that they keep all of this data in, so that anybody who wants to go back in and acquire this data is able to go to this same place.
Okay, I got that.
And they actually service and maintain these giant silos.
Okay, got it.
When it comes down to the cost and who pays for it, as you had asked a minute
Yeah.
ago, the doctors pay for it.
Okay.
And basically, it's really good idea for many simple reasons. One is, of course, you no longer have a server on site. So you don't have to have an IT person working for you to maintain your server. Now, you do have to have an IT person because you're still going to have computers. You're still going to have software that has to be managed inside, but you're not going to have the cost of the updates for the server and the programs that are involved, the virus protections, the firewalls. All of that stuff is now maintained by a company like AdvancedMD or Allscripts or eClinical, or there are hundreds of them out there that you could choose from. Now, the doctors pay a monthly access fee. Now, when I say doctors, that also includes the practice nurse practitioners, or the physician's assistants, because they are going in and they're massaging that data. So basically what happens is it's not like Dr. Jones has his data on that site and Dr. Williams comes in and goes to that data. That's not true. They still have their individual. It's divisioned out. So there's partitions in Advanced MD. They may have, and I'm guessing right now, but we'll say they've got 20,000 doctors that are utilizing it. Each one of those doctors has their own petition. So it's like your own book. At this point, nobody can access that data except the doctors who have paid the fee to do it. And really what you're doing is you're paying for your storage, but you never have to add to it. It's there forever. So if you need 1 terabyte, 2 terabyte, 10 terabyte, 4 terabyte, that's all absorbed by Advanced MD or whoever, because they're the ones that you're paying the fee for.
Okay.
And the whole principle is that once, as I mentioned earlier, once it goes nationwide, where everybody is actually using an EHR, EMR, and doctors, or you're traveling and something happens, it will be accessible, turned on to be accessible by your Social Security number. So they, no matter where you are, you can, the doctors will be able to access your database no matter whose it's in. Now, I want to make this clear. This is not new. This has been going on in Europe, been going on in Canada, been going on in Australia. Countries all around the world, the ICD-10s have been being put into place, but it's not been turned on.
Mm-hmm.
So that's the goal, that if everybody gets on the same system, when they turn it on, everybody will be able to access, everybody, or all the physicians who need to access your information would be able to. It's kind of like what happened back in the 60s when they tried to get everybody to go metric. And then the United States said, oops, we don't want to do this anymore. So they didn't. So that's why we have metric and we have the other offshoot of that. So this time, hopefully it's going to work for everybody. That's the goal for the EMR, EHR systems.
Got it. Okay. We are speaking with, excuse me, Jerry Quintana and John Boudreau with ObamacareAudit.com and Medical Management Systems. If you have any questions, you can reach them at 727-207-0979. We're going to take a quick break and hear from our sponsor, and we'll be right back after this message. And we're back to our program today. My name is Terry Borg with Go Mind Your Business, and our program is sponsored by Extreme Marketing Concepts, putting your business in front of the hungry herd of buyers who are looking for you right now. You know, one of the things that most businesses have trouble with is that they have a great reputation and nobody knows about it, or they have a terrible reputation and everybody knows about it. If either one of these problems are affecting your business, give them a call at 813-863-1452. We are speaking again with Jerry Quintana and John Boudreau with the ObamacareAudit.com. You can reach them at 727-207-0979 if you have any questions. So, Jerry, I want to talk about the stimulus package that's out and why it's in place. Can we touch on that a little bit?
Sure, that's not a problem. Actually, the government has been trying to get doctors to go with an electronic medical record for a number of years, and with very little success, actually. And so what they decided to do is to pay the doctors in order to implement these systems, because these systems are not cheap. Some of them can be very expensive. So what they did was they set up a program where you implement an EMR. You have it all set up, and you use it in a certain way, and you meet certain core criteria and then certain elective criteria. And when you meet those criteria at the end of, well, for the first stage of meaningful use, when you meet that criteria of collection of 90 days, you can then submit this information to the government, and when they approve what you've done, they will pay you for that first time payout $18,000 per doctor.
Mhm.
So you do the math. If you've got a number of doctors in your office, you implement this system, and you meet that first stage of meaningful use, each one of your doctors gets a payout of $18,000. Now, the government's not stupid. They're not just giving money away. That will go toward paying what it costs them to implement an EMR system.
Mhm.
Okay, now, once it's in and they're using it, then you have the next stage of meaningful use. And when they complete the criteria for that next stage, they get an additional $14,000.
Okay.
Okay.
Mhm.
After that, it's $12,000, and then $12,000 again.
Okay, and that's to keep the records available and make sure that all the doctors maintain and stay on this program.
Well, they do that. Plus, they have to use things like ePrescribe, where they actually do their prescriptions online. They communicate with the pharmacy online, and all of this is done paperless.
Okay.
That's just one of the core objectives. They actually have to meet 10 core objectives and 15 electives.
Okay. So
Okay.
what happens if the physician or the physicians group doesn't want to be on this electronic medical record
Uh,
portal?
another good question, and this is incredible, because this is what we tell the doctors. You can do it now and get paid for doing it, or you can wait, because at the end of 2014, they have to have an electronic medical record. It is mandated by the government. So you can either do it and get paid, or you can do it on your own dime.
Okay.
So
So, the doctors should make an intelligent decision
And
on,
exactly, make some money while
Okay.
you're implementing this.
Okay. And then this is where, you guys are coming in, and you're implementing this for them. And then are you helping them select which of the portals to stick the doctor on? Like, John, you were talking about the medical, you said there were like several different carriers.
Yeah.
So you're helping them select the best one for their organization, or
abs-
I'm just a little
Yeah,
confused there.
no,
Sorry.
you're right on the money,
Mhm.
because really what happens is there's a lot of good carriers out there.
Mm-hmm.
However, a lot of them are designed specifically best for specific specialties.
Okay.
We have a couple that are specific for ophthalmology. We have a couple that are specific for cardiology. And then or orthopedic, or all the way down through. Now, one thing I want to make really clear here is that establishing an EMR or an EHR is not expensive.
Mhm.
It's pennies compared to the stimulus package that these folks can receive.
Exactly.
If you've got a 3-doctor practice and each doctor qualifies from day one for the stimulus package all the way through, that's up to $64,000 they earn per doctor. And in most cases, they can establish an EMR for somewhere between $8,000 and $15,000. So there's a huge discrepancy there over
Mhm.
what it costs to do it and what the remunerations are for having done it.
Okay.
Now, as Jerry mentioned, at 2014, if you put it in after that point, there is no stimulus bucks, and you're going to get fined for every month that you don't have it.
Sure. Well,
So
that's
do
where
you-
the government's going to make their stimulus back, right?
Well, at this point in time, I believe around the nation there's still about 60% that haven't installed.
Okay.
So it's not like it's just a few that haven't done it. And this has been going on since 2009. So
Okay.
this is not brand new. Some people who put it in 2009 didn't know there was a stimulus package involved in it. So they can still qualify.
Okay.
So just want our listeners to know that, just because you put it in and you didn't know, you didn't miss the boat. The boat is still afloat.
Okay, great.
And they're looking for passengers.
Got it. Okay, great. Um, when they get this implemented in their office, do they get some sort of a certification?
Well, we have a certification that we do when we do the Obamacare audit certification. Yes, there are certain criteria that are going to be qualified in each stage for them to receive that certification. Now, the certification simply means that they meet all of the requirements in order to move forward to obtain their stimulus packages from day one. Also, it's going to mean that they are implementing everything in compliance with HIPAA, that they're implementing everything in compliance with what's necessary for the protection of the data through their IT department as well as through their staffing, etc. It's going to make it so that they're financially stable and they're able to move forward as Obamacare rolls out so that the practice is going to maintain its profitability and the doctors are going to be happy and the employees are going to be happy too because the paychecks will be there.
Okay.
So it's a continual thing.
I got that. Jerry, are there any benefits from gathering all the information that the doctors are required to supply?
You mean besides getting the
Certification.
stimulus money?
Yeah. Well, I mean that's pretty huge. But is there any other benefits or?
It actually, there's a tremendous benefit, and again, you have to go back to a global-minded community.
Mm-hmm,
The doctors are here to heal people,
mm-hmm.
and for the most part, that's exactly what they want to do.
Okay.
And so, when you tell a doctor, if you take this information and you put it into your EMR, other doctors are going to be able to use this information in order to improve the health of your patient. That's huge,
Mm-hmm.
because it can allow a doctor that can see, you know how you say a fresh set of eyes
Mm-hmm.
can see something that the other people haven't seen. Well, that's exactly what's going to happen with the EMRs. When other doctors are looking at these, the referral doctors and even like the labs and things like that, they'll put information into these EMRs. It's going to build a much more comprehensive story of this person's health record. And so from that story, you can have a doctor that'll see something that someone else didn't see and maybe catch a cancer that had particular symptoms that nobody else saw. They'd be able to see this, recommend a treatment, and save a life.
Mm-hmm.
And when you're talking about the terabytes of data that's going to be available, I mean, you can open this up, and I mean, just imagine what's happened with this latest little girl that got healed of AIDS.
Mm-hmm.
They went back and looked at those records to see what exactly they did that caused this person to be healed, rather than just a medical maintenance.
Got it. Okay. But I don't know, John, the government having access to all of our personal information, it's designed to protect us. And here we're giving it over to the government to say, here, this is who I am. They're going to be looking at things. What if I do have cancer and, I'm an expensive person versus a person who's doesn't have cancer and they're inexpensive, or you can see every little thing that's wrong with me, every little medication that I take, everything. Do we want them to have all that power?
Well, you know what?
Or is that a different discussion?
Well, no, we're going to hit on both ends of that. First off, what Jerry was talking about is very accurate.
Mm-hmm.
The other part that goes along with that is just think how much money can be saved from the lack of duplication of tests.
Mm-hmm.
Can you imagine if you just went through a complete medical workup here in Florida and you went up to visit your relatives in Chicago and had a car accident?
Mm-hmm.
And what are they going to do? They're going to run all the same tests over again because they don't have access to your medical records. So they don't know where your health stands. So all those x-rays, the MRIs, all those things are going to be done in duplicate again. Where if it's available in the cloud, they could pop it up. They would have a starting point to know exactly where they're going from. Now, again, good point, bad point.
Mm-hmm.
If you read the Obamacare or the Affordable Health Care Act, it's going to tell you that I'm sorry to tell you, but you're 69 years old and you need a new hip, but I have somebody who is 42 who's contributing to the monetary welfare of the country. He's still working for a living and he needs a new hip. So who's going to get the hip? Believe it or not, that's in the Health Care Act.
Mm-hmm.
That the young fellow will get it and you may not. There's going to be end-of-life decisions that are going to be made by the hospitals and by the doctors instead of by you.
Mm-hmm.
And they're going to recommend, oh, this person's got second-stage cancer and she's 82 years old. Well, she's lived a good life.
Mm-hmm.
So she's terminal in 3 months. Where if, we got aggressive, maybe she'd live for another 2 years.
Mm-hmm.
Those decisions are going to be made. They're going to be based on money. They're not going to be based on your welfare anymore. These things are all in the Affordable Health Care Act. Other people are going to make decisions for your life.
Mm-hmm.
Yeah, it's going to be an open book. When you go to the hospital, you're, say you're a self-employed person
Mm-hmm.
and you choose not to have health insurance.
Mm-hmm.
This is one of the other caveats that's coming forward. And you're paying the fine. We'll say your fine is $2,000, $5,000 a year.
Mm-hmm.
But in order to have health insurance would have cost you $12,000. So you're 36 years old, you go to the hospital, and they discover you have cancer. What's your next decision? Which healthcare insurance company am I signing up for?
Mm-hmm.
Because there's no pre-existing condition clause.
Right.
So all of a sudden, the insurance carriers are getting all the very sick people.
Mm-hmm.
They're not getting the health people on their rolls. So instead of making money, spending money. How long can that continue before it becomes a roadblock for insurance carriers to be able to provide health insurance? You cannot buy private health insurance in Canada
Mm-hmm.
or in England, anywhere, because now it's all government run because the private insurance companies couldn't afford to sustain themselves.
Mm-hmm.
So are we going there? I don't know. But boy, it sure looks like it.
Okay. So, on that note, let's talk briefly about how you can come in and optimize a practice.
Okay. One of the first things that we do, and I'll speak from my side
Mhm.
with IT.
Okay.
The first thing we do is we run a HIPAA compliance audit,
Okay.
and we make sure that everything in the office is HIPAA compliant. While we're doing that, we evaluate their computer systems and make recommendations on either upgrading their systems, leaving their systems alone, or replacing their systems entirely. Once that's done, we look at the software that they're using, and we make recommendations there as well. So that includes the EMR, that includes their operating systems, that includes, do they want to use tablets, iPads, whatever, in order to facilitate their EMR and during their procedures. We look at all of that from an IT side, and when we're finished, we give them a recommendation, and then we implement a turnkey solution for their hardware and software.
Okay, great. And then Jerry, from your side, how are you optimizing the practice?
Well, the first thing that we're going to do when we go in is we're going to look at the staffing allocation.
Mhm.
We're going to make sure that there's not a duplication of effort being done. And that happens sometimes. Sometimes it's willful, sometimes it's accidental. Sometimes a doctor or someone in the office will facilitate extra duties for a member of the family who wants to come to work for the practice. And that may be under the direction of the physician or not. But we're going to do it objectively. We're not going to be subjective about anything that comes in. We're going to do the review of the office staff, the duties, the procedures, everything that happens on that end. We're going to co-work with Jerry and his team. And what we're going to do is we're going to do a demographic of their practice, billing, and accounts receivable system to make sure that what the doctor is billing is what the doctor is receiving. I mean, let's be honest, we all love to be charitable.
Mm-hmm.
I mean, we all have our favorite charities, but the government and insurance companies should not be one of them. And when a doctor doesn't get paid what he bills, who's benefiting? Not his patient population and not him. Not his staff, not anybody who's associated with him. But the government gains because if you don't get your Medicare or your Medicaid dollars, it stays in the government fund. If you don't get your insurance company money, guess what? The insurance company's got it, and they're happy. The more you don't pay them, or the more they don't pay you, the more you pay them. So, for instance, we have a practice that we're working with right now, or we're just getting on board with right now, who's actually losing $100,000 a month. Because if you have an accounts receivable of $1 million, 10% of that is dropping off every month. Where's it dropping off to? To charitable donations. So let's pull the money back in. The doctor wants to give money to the charities, let him give them to who he may. But let him have that choice. So those are the primary things that we come in and do. We're also going to do a staffing allocation for the doctor in the sense that, okay, we find out that there's 6 people in this multi-specialty group that really are doing work that is already done by somebody else. We're not going to say to the doctor, you have to fire those people. We never make that recommendation. We tell them what's happening and what our suggestion would be. But we do have a placement organization in our company. So if he says, well, if you can find other opportunities for these people, I would appreciate it, then we will do that. That's part of our deal too. We're not charging doctors for doing nothing. We don't believe in that. There's no such thing as getting paid for idle work. We do our job under his direction and under the direction of the audit that we'll present him. When we're done, we will give him a complete write-up of everything that we've discovered through our audit. And maybe he's completely 100% satisfied with what he has, and an Obama certification would be eligible that he should receive from us. However, if we find things that are exceptional that shouldn't be, or exceptional in the case that they shouldn't be happening in the practice, we'll make the recommendations that he can be more compliant and more comfortable in his practice and profitable at the same time.
Okay, I got that. Jerry, is there anything else that we haven't talked about today that you want to make sure that we discuss?
Let me think. No, I think we
Got it?
pretty well covered it. What
Okay,
do you
perfect.
think,
How
John?
about John? Is there anything else? We could talk all day. We only got a couple
Right.
minutes left on our program, so
Well, really, when it comes right down to it, it's very simple. Doctors know that the problem's here. Physicians know, their office managers know, the supervisors know. Nobody is to blame for the errors that are happening. It's the way the system is set up. The main thing that anybody in the billing department needs to know is it's impossible for an internal billing organization to manage the accounts receivable and billing processes of a practice because they have other jobs to do. That's why companies like ours offer the service we do at the reduced rates that we offer it at, to make them more profitable and make them more comfortable at what they're doing, because there still needs to be billing people in the practice. Somebody has to do the coding and the arranging and all of that. Just that all of the collection of the funds and all the chasing of the money, that's something that we take out of their hands because we have professionals who do nothing but that. So we make sure that they receive their funds within that first 21 days. We have about a 90% recovery rate of applicable funds in the first 21 days. So by the end of the first 60 days, they've received 99% of all their funds. And that's just a real substantial difference in a practice.
Awesome. Okay, that's terrific. If your practice needs the help of Jerry and John, you can contact Medical Management Systems by reaching them at 727-207-0979. Again, 727-207-0979. 0979. I know they're happy to answer all your questions, take care of anything that you might need, and just be able to make you have a little bit more peace of mind in your practice. And I definitely recommend you giving them a call. You've been listening to Go Mind Your Business here on the All Your Business radio show, part of the TalkWad Network. And today we are coming to you live from our Clearwater studio. I want to thank you so much for joining us today. And until next time, I remind you to go mind your business. Have a great day.
Thank you for listening to Go Mind Your Business with Terry Bork, presented by Extreme Marketing Concepts. If you want to drive more traffic, dominate the market, and crush your competition, find out how by visiting our website, www.extrememarketingconcepts.com. And join Terry next time for another episode of Go Mind Your Business.